Welcome to another PrecisCa tumor board. We've got a great number of cases to discuss today, a lot of interesting and challenging cases. Before we get started, I would just like to go around the chat room here and introduce anyone. I'm Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine, and I'm joined today by a wonderful faculty, multidisciplinary faculty. I'll start with Dr. Kamage. Dr. Kamage.
Hi, I'm Ross Kamage. I'm a medical oncologist. I'm the director of thoracic oncology at the University of Colorado.
Great. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging and the vice chair for education at Memorial Sloan Kettering Cancer Center, and also professor of radiology at Weill Cornell Medical College.
Great. Dr. Force.
Hi, I'm Seth Force. I'm the chief of thoracic surgery at Emory University Hospital in Atlanta, Georgia.
And last but not least, Dr. Curran.
Hi, Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and adjunct professor at Emory University.
Great. Welcome, everyone. Pleasure to have you all here. And just a brief summary of this second case, 73-year-old male with a past medical history of bladder cancer, diagnosed and treated in 2002. Has a history of hypertension, diabetes type 2, COPD. He has a 50-pack-year history of smoking, and he's still currently smoking 1 pack a day. Found to have a 1.3 by 0.9 centimeter right upper lobe lesion on screening chest CT with PET evidence of hypermetabolism. The biopsy is done. It reveals squamous cell carcinoma. He is initially planned for surgery. However, he becomes ambivalent, and there are questions about how to manage a patient like this who may not want surgery. Additional questions here is how would you push for an EBUS without any evidence of adenopathy on the PET scan? And then some questions about the radiation therapy and using conventional radiation to the lesion. So we'll try to get everyone involved here. So this is a patient who presented with a screening CT scan and a smoker's cough. Remember, heavy smoking history here. His performance status is 1. His past medical history is consistent with bladder cancer diagnosed and treated in 2002, hypertension, diabetes type 2, COPD. As mentioned before, he has a 50-pack-year history of smoking. He has a history of right humeral fracture, 2 previous knee surgeries, and multiple cystoscopies for his bladder cancer. His social history, most relevant, is consistent that he's still a current smoker, smoking a pack a day, and is smoking for the past 45 years, still smoking. Family history, he also has an exposure to an exposure to Agent Orange and asbestos. His family history is consistent with a mother with colon cancer diagnosed at 78. So we don't have the imaging here for Dr. Ginsberg to layer in her insight, but we do have the report. So in August 2020, he has a CT without contrast that reveals a spiculated pulmonary nodule measuring 1.3 centimeters anterior to posterior by 0.9 centimeters by 1.1 centimeters with central air lucency within the posterior medial aspect of the right upper lobe. Fast forward roughly 6 months, so there's a little bit of delay, nothing happens. The CT chest without contrast again, showing increased size of this right apical mass. It spans now 2.4, so going from 1.3 to 2.4 centimeters when you compare it to the scan from August 2020. And this is followed up by a PET CT that confirms this mass is 1.7 centimeters by 2.6 centimeters. It has an SUV of 4.1. The report is malignancy until proven otherwise. There's no evidence of disease outside the chest. The patient undergoes a CT-guided biopsy that reveals squamous cell carcinoma. The cells are positive for CK7, P40. They're negative for GATA3, CK20, and TTF1 in NAPS and supporting squamous cell. And the GATA3 negativity does not favor metastatic urothelial carcinoma, given this patient has a history of bladder cancer. So the surgery is initially planned, but the patient is delayed and finally decided against surgery. Radiation is pending, and obviously systemic therapy is pending. So I guess we'll stop here, and probably the first physician to engage on this panel would be Dr. Force. We don't see the images, unfortunately, Dr. Force, but can you walk us through a couple of things? One, how you generally approach a lesion like this, even though I know you can't see it in the right upper lobe, and then how you approach a discussion with a patient who is a little hesitant for any sort of surgical approach?
Sure. So, I mean, and we're also missing some key data, pulmonary function testing, echocardiogram. Does he have any heart disease that's undiagnosed? It's a little bit of a shame because at least on the where you described it, when the tumor was 1.4 centimeters, it was potentially amenable to a segmentectomy, and particularly a right upper lobe posterior segmentectomy, which are fairly straightforward operations. And so we know that from some of the data that we have thus far, that it appears for tumors under 2 centimeters, a segmentectomy can have equivalent 5-year survival to a lobectomy. Once we get over 2 centimeters, that data washes out, and it's really a lobectomy, the definitive operation. So by delaying, he's now, kind of put himself into a situation where he really needs a lobectomy. Granted that those can be done, obviously they're done minimally invasive, and we really can push the type of patients that we operate on. So, it's really sitting down, talking with the patients. And I think if he doesn't have surgery right now, even though there's no evidence of lymphadenopathy or PET avid lymph nodes, if he gets, non-surgical therapy, I think he has a higher risk of a local failure, because we know that once tumors start getting up over 2 centimeters, the local metastatic rates and lymph nodes start going up over 20%. So, that I would talk, the way I talk to my patients, especially if they're higher risk, I say, look, surgery is a definitive operation. It's likely to in this case, have a better, long-term survival than non-surgical therapy, but it has higher risks. The less risky treatment, stereotactic radiation, is going to be much less risky, much easier recovery, but it's going to have a higher local failure rate, especially for a 2.6 centimeter tumor. And that's the choice that they have to make.
Great. So let's say that Dr. Force, you have this conversation with him, and the patient, declines despite your push to say that this is something that could lead to a very good chance for cure. I'm glad you mentioned some of the other workup that needs to happen here, including the echocardiogram and the PFTs. Those are critical, I think, to assess the surgical candidacy for a patient. But let's say this patient decides that he doesn't want to go through surgery. Let's say, Dr. Curran, the patient ends up in your office discussing, he had a discussion with Dr. Force. This is not something he wants. First question, would you push for an EBUS despite no evidence of adenopathy on imaging or PET-CT? The false negative mediastinal rate of PET-CTs, I've heard different numbers. But is this something that you would want to know prior to pursuing some sort of local ablative approach?
Yeah, the answer would be yes on that, Dr. Levy. Particularly as Dr. Force said, the lesion has grown. There is a real risk of having positive mediastinal nodes with that size, upper lobe squamous cell. And I think anyone would feel more comfortable offering an SBRT approach to him if EBUS staging came back negative.
Can I give a contradictory response to that?
Huh?
Can I give a contradictory response when you're done?
Sure.
I can't wait. The stage 1 debate, SBRT versus surgery. This is the whole point of the case. So
No, it's not about SBRT. It's that we know that the sensitivity and accuracy of EBUS for non-enlarged mediastinal hilar, non-PET avid lymph nodes is extremely low. So I think the benefit of doing kind of a fishing EBUS when there's no radiographic suspicion of metastatic lymph nodes is extremely low. And for the mediastinum, particularly, one of my partners was the PI was his study. It was a multi-institutional randomized prospective trial looking at mediastinoscopy for T2N0 tumors. And we really found there was no benefit for mediastinoscopy because the rate of lymph node disease is so low. And that's for PET, non-PET avid, non-enlarged mediastinal lymph nodes. So I think if you don't have suspicion, I think that your positivity rate is going to be extremely low.
Dr. Curran, back to you.
All right, Dr. Force, thank you. I miss being with Dr. Force every week now. So,
So let's go ahead, Dr. Curran.
So let's assume the option, he's declined surgery. I've again encouraged him to go back to Dr. Force and consider it. But once he's at a point where he will not consider that, the ability, it sounds like anatomically a lesion that would be amenable to an SBRT approach. It does not sound too central. So it would sound like a 3-fraction regimen of 18 gray prescribed to the tumor with a couple millimeter margin, accounting for any movement of the lesion, and respiration would be a good approach. It's typically given on a Monday, Wednesday, Friday. And if you look at the medium long-term data from the RTOG trials prospectively in these types of patients, probably local control is in the 70 to 80% range with this approach.
Dr. Kieran, I'll give you the
not 100%, but better than no treatment.
I'm hearing a 3-fraction treatment of 18 gray Monday, Wednesday, Friday would suffice in a case like this, assuming that the EBUS was negative, correct?
Correct. Or if Dr. Force persuades me and others not to do the EBUS, yeah, based on the PET CT. And that's 18 gray times 3, so a total dose of 54 gray.
You know, there's been a tremendous amount of, and I thought this is where the conversation would go, a tremendous amount of debate on is there an optimal treatment here, surgery versus SBRT for a T1 N0 lesion or T1A or B N0 lesion. Dr. Kieran, do you think that surgery is a better chance for cure versus your approach, or are they fairly equivalent? I mean, is this a conversation where they need to see both disciplines, or should surgery have the prerogative to initiate that conversation and make that decision first?
Yeah, that's a great question. I stand by surgery being the standard of care for such a patient, for a patient who's medically marginal for surgery or medically inoperable or refuses surgery. I think SBRT is really the best non-operative approach. We have tried to do several randomized trials of operable patients, surgery versus SBRT. RTOG Foundation did it in China, did not enroll enough, as did the American cooperative groups and European groups. There is a trial going on in the US Veterans Administration called Valor, being led by Dr. Moganaki, which is enrolling, has over 100 patients on it, and looks like we'll be able to, at least in the VA population, address this issue. And again, the real question is really both progression-free survival, but most importantly, a survival endpoint.
So that's a nice overview. Dr. Kamage, I'll put you on the hot seat just in an unfair question. Let's say this patient did have a local regional recurrence post-SBRT, still didn't want surgery, and Dr. Kieran said there's no real, I really have not been able to, or the patient declines radiation or reirradiation or some sort of modality like protons. Is there a role for systemic treatment in a recurrent squamous cell post-radiation? And if so, what options would you necessarily deploy here for a patient like this?
I mean, I think it's a great question. I mean, I think one of the questions you'd ask the patients, you sit down and, you've got to look at their other comorbidities, their longevity, because you're going to give them some toxicity here. And they may say, look, I'm pretty good. I don't have any symptoms from this. There's just a little bit of avidity on my scan. You could even entertain the idea of the interesting, if Dr. Force thinks about this, a sort of, radio frequency ablation. This is done by some surgeons or some interventional radiologists. That's kind of in the hands of the provider as to whether that's useful. But if you were going to give systemic therapy, let's not forget that we do have immunotherapy here. So we don't know any of the molecular information on this sample. If they had a PD-L1 of 70, 80%, probably I would give them immunotherapy and tell everyone else to stand back. If they had a PD-L1 of 10%, I think it's a much more debatable situation.
Great. All good points on this case. So,
Dr. Levy, I would like to bring up one point. We learned that this patient was still smoking a pack a day. And if he agreed to surgery with Dr. Force, I know, would have been emphatic about quitting before resection. I would also be emphatic about that if he were to engage in a course of SBRT. Radiation, as with almost any medical intervention, is more poorly tolerated in current smokers. So we would do everything within our power to get him to quit smoking as well.
Great. A very good, an important point for all of us, no matter what modality we're deploying, even if we're giving systemic treatment, targeted therapy, immunotherapy, certainly trying to get our patients to stop smoking is important. So we're going to move on, but parting shots, I just want to summarize this case and what our recommendations are. It sounds like there may be some mixed recommendations with regards to the EBUS. That it may or may not be of value if it's truly node negative on PET, and that if this were node negative, excuse me, if the EBUS was done and it was negative, or if the decision was made not to do the EBUS, that a 3-fraction 18 gray Monday, Wednesday, Friday treatment would probably be the optimal way to treat this patient.